In terms of diagnosis, surveillance is defined as the art of listening during a child checkup. Okay, and what is important there is what the parent told you, how they told you, how the question was asked, and that is really the art of medicine. Surveillance is just we're keeping an eye on everybody, making sure that no one stands out. Screening is when I specifically want to be looking at them. So even if there's no parental concern, I want to make sure that I check everybody for a particular problem, whether in this case is autism, which we do at 18 and 24 months, or whether we do general development, okay? And then that, if the screening is positive, then we're going to move to a formal evaluation. So let's talk a little bit about the screening. We have the MCHAT, and what I have done in this slide is that I have highlighted those very significant milestones that we talked about previously that will raise the biggest concerns and that have been shown to be the most sensitive for the autistic spectrum disorders. So it talks about the proto-imperative pointing, that, does your child ever use his or her index finger to point to ask, or to point to ask for something? Does they use the index finger to point to indicate interest in something? Does your child ever bring objects over to you to show you something? If you point to a toy across the room, does your child look at it? Does your child look at things that you're looking at? Does your child try to attract your attention to his or her own activity? So all of these have to do with joint attention. All of these have to do with theory of mind. Again, the MCHAT is provided by the American Academy of Pediatrics as part of their toolkit, which is fantastic and offers great resources that you can give the parents, general information on autism, wonderful links. So I would encourage all of you to get it. It's a great, great resource. If your screening is positive, whether it is a motor screening, a language screening, an autism screening, then the next step comes in the diagnostic evaluation. And it is very important because, as you all know, nowadays a diagnosis of autism will buy you a higher level of services than many other diagnoses, and the evaluation has to be done in a very appropriate way. So we need to make sure that we have a sensory assessment, that the hearing is appropriate. We need to assess the level of developmental performance, and then we need to look at the tools that are designed to assess autistic behaviors. We need to look at a developmental history to see the progression of symptoms over time, and we need to look at speech language assessments to particularly focus on the semantic pragmatic language component. We look at tools that are observational tools, no different than the ones that we use in ADHD, where caregivers are providing observations. Problem is, these tools are not always very effective on children under the age of 3, particularly children that have no language, because a lot of the things are going to come out positive. So this is where the clinician's intuition and experience is going to play a role in the diagnosis of the child. We may get audiologic and speech language evaluations. If we see dysmorphisms associated with the child, then we need to do our genetic studies, high resolution karyotype DNA studies for Fragile X syndrome, because those are the most common ones. When you have a history of regression in developmental functioning, the most important thing to look for is a progressive encephalopathy. And at that point, either you're going to be looking at something like a type of epilepsy like Landau-Kleffner, or you may be looking at a progressive encephalopathy as a result of a space-occupying lesion or a metabolic disorder. So typically those kids get organic and amino acid screens. They get, in neuroradiological studies like an MRI or a CT, depending on the concern. So we try to evaluate those very aggressively, because if we have a progressive encephalopathy, we have to address that as a medical condition. In terms of causes, really, there's no identifiable cause. There's not a biological marker for autism. We know that there are certain genetic disorders like Rett syndrome that will present with autistic spectrum symptoms. We know that there will be regression in some aspects of developmental functioning in those kids, and we see an arrest in brain development. But again, there's no one specific cause of autism that we can identify. We see that there is a genetic predisposition, and as we've seen identical twins, we can have up to a 60% concurrence of autism. Siblings, we have a 10% incidence and about a 2% incidence in other family members. So it tends to run in families. That's why the family history is so important. In terms of management, we always have 4 areas of management. We have educational management, and educational management is divided into 2 main components: remediation and accommodations or circumvention. Remediation is really emphasizing the weaknesses. We're going to strengthen the weaknesses. The younger the child, and we're focusing on early identification, therefore our interventions are going to be very aggressive in terms of remediation, and we want that there. So that's specialized services, typically speech language, OT, special education. And what we're doing is trying to strengthen the weaknesses. Accommodations is focusing on the strengths. And a common accommodation that we use in children with autism, for example, is technology, visual strategies for improving communication, picture exchange communication system, Proloquo, that has incorporated the icons in Apple tools like the iPad or the iPhone. And what we're doing is, because the child can recognize icons or visual patterns, we can use those to generate sentences. That usually requires some behavioral intervention also. Accommodations really come in 3 forms. You can use technology, you can accommodate for rate, or you can accommodate for volume, which is pretty much the same thing. You give them more time or less work in the same amount of time, or you let them listen to it, see it, say it, instead, whatever. Psychological interventions. The younger the child, the more the emphasis is on the adults. An adult-focused psychological intervention is really behavior modification. Behavior modification means that the adult that is dealing with the child must change the way that he or she deals with the child so that the child changes their response to them. The change is external to the child and is under the control of the adult. So that is critical. And pretty much every aspect of intervention requires some behavior modification. And many of the strategies that are taught in the individual therapy session need to be generalized to other environments. And the parents really work as co-therapists in the management of their children's problems. But it's important to protect the parents too and make sure that we don't ask them to turn their homes into a therapeutic setting, because they're the only people that can give children a home, and they need a break too. If the parents burn out, the kids have nowhere to turn. Nobody will care for them. So one of my main goals is to ensure that the parents are protected, that they don't burn out, so that they can continue to provide for the children as well as possible. If the children are older and they have good language skills, we can work on cognitive behavior therapy, because that helps with the anxiety. Medical management is very important, and as physicians we can do one of 2 things. Either we prescribe for you or we cut it off. Surgery has not been shown to be very effective in the management of developmental problems, so we don't use surgical procedures very often, but medication has been shown to be very effective. Now with DSM-5, you can actually make a diagnosis of ADHD in a patient with autism. I have been treating patients with autism for ADHD for many, many years, and we all know that, so that's one of the things that we have accommodated. The last area of environment is home and school, and there has to be a lot of integration of these 2 environments. So that's what a good coordinated management should be, working on developmental and educational interventions that strengthen the weaknesses, those accommodations that are going to help the child meet the environmental demands without significant adaptations, working on behavior management to address the symptoms, and then medications when needed. And then all of these services need to be coordinated between the two main environments where the student will be, which will be home, where the child will be, which will be home and school. Interventions work best for those kids that are high functioning, for the kids that have the less severe behavior problems, and for the children who begin to receive intervention before 60 months of age. So that's why we're talking about this today. I want you to be very aware of those patients that you have that may be at risk for a developmental problem, for an autistic spectrum disorder, and make sure that they receive services before they get to elementary school, because we have a greater likelihood of having more success. Intensity plays a major role on the efficacy of the therapeutic services. With the shortage of fundings that we have right now, we have seen many of the intervention services being cut, and they provide 1 hour of service per week. That may not be sufficient to address the child's needs. When the kids get to school, they're receiving some level of intervention, 6 hours a day, 5 days a week, 10 months a year. That's intensity. If you're trying to lose weight, if you only go to the gym for 1 hour a week, you'll never lose the weight. You got to go more often. You got to watch what you eat. You have to exercise, all of these things. Well, it's the same thing with these children. You have to provide intensity in the treatment for it to be effective. And when it's done, it works very well. In terms of what we want to accomplish, in child development and behavior, we don't cure anything, we manage it. So what we want to do is to help the children develop to the best of their abilities, whatever that best may be, and to minimize the complications that are resulting from the disorders that they have. We want to make sure that we provide parental support, because the parents are the ones that are going to be coordinating all of this care. And we have a very complex system that is not designed to meet the child's needs. The system is designed to ascertain who qualifies for services. You may qualify for something that you don't need. You may not qualify for something that you need. You may not qualify for enough. So we need to provide that support for the parents. We need to make sure that they don't burn out. Many of the children that have the severe behavior problems, these parents need respite because they need to be able to recharge the batteries. We need to be able to provide good parental support, prevent parental burnout. I also talk to the parents about making sure that they take the time to take care of their own needs. People cannot give you what they don't have. Having a child with special needs brings a tremendous amount of stress into the family, and having stress in the family is like having cabin decompression in an airplane at 44,000 feet. At that point, everybody's out of oxygen. And what the flight attendants tell you is that when those masks come down, you need to put your mask on first if you want to help someone else. And there's a simple reason for that. People that cannot breathe cannot help other people breathe. So we need to help the parents of our patients breathe. They need to get the support that they need. They need the respite. If there are two parents, then they need to take time together and nurture their relationship, because two can do the work of three, but one cannot do the work of two. We need to make sure that the parents recognize that this is not their fault. It is simply their problem, and they have to manage it. They have to be their child's advocate, but they have to be smart about it too. We need to teach them how to listen to the people that provide services. Did they tell you your child did not have a problem? Or did they tell you that your child did not qualify for services? Because those are two different things, and understanding the language will be very important, because in the end, everybody wants to make sure that the kids get the best services possible. So support the families, provide behavior support. If there's a need for medication, let's educate the parents on what it is and make sure that it's done properly with good monitoring. Identify your target symptoms, assess the severity and the frequency, and then you can see if they change with the medications that you're prescribing. Let's make sure that educationally they get the services that they need so that we can remediate their problems, so that we can maximize function and minimize complications. Check the toolkit from the American Academy of Pediatrics. That will provide you with great information on how to manage your patients with autism. Have a good day.